Now, in this lecture, we are going to discuss dental management of patient on dicomarol. Actually, this lecture is to continue with the previous lecture. We discussed dental management of bleeding disorder and we discussed dental management of hemophilia. As we mentioned before, that bleeding disorder might occur due to even deficiency in the number of the platelets, what we call the thrombocytopenia, or due to vascular wall changes, or due to deficiency in one of the clotting factors of the hemostatic mechanism, such as deficiency factor 8 as in case of hemophilia, or deficiency of factor 9 as in case of Christmas disease, or even in case of von Willebrand's. Here we are going to discuss patient taking anticoagulants, particularly oral anticoagulants such as dicomarol or even warfarin. Because also there is heparin, but heparin usually is taken as a parenteral, that means intravenous. Anticoagulants, group of drugs used to prevent blood coagulation, what we call to make the blood more thinner, to pass smoothly within the blood vessel to prevent its coagulation. Actually, dicomarol or warfarin, the action is to antagonize the effect of vitamin K, because vitamin K actually is responsible for the synthesis of certain clotting factors in the liver, such as factor 2, factor 5, factor 7, or even factor 10. So the action of anticoagulants is to antagonize the action of vitamin K. These drugs can be used in certain situations, such as in case of or to prevent myocardial infarction or stroke, or in case of deep venous thrombosis, in case of prostatic or artificial heart valve, in case of coronary bypass operation, and so on. So, how we can manage patient on dicomarol or warfarin? First of all, detection by history, we have to ask the patient about the conditions I mentioned previously, such as if the patient had previous attack of myocardial infarction, or the patient has deep venous thrombosis, or even the patient with artificial or prostatic heart valve, or even patient underwent bypass operation, or what we call coronary bypass operation, because usually anticoagulants can be prescribed in these conditions. Once we detect the patient, we have to consult the physician, because the physician will order prothrombin time, as we know that prothrombin time measures the extrinsic and the common pathways. So the prothrombin time, in order to perform surgical operation for those patients taking anticoagulants, the prothrombin time should be 1.5 to 2 times less than the normal. As we mentioned in the previous lecture, that the value of prothrombin time within seconds. So it should be 1.5 to 2 than the normal value. Level of anticoagulants also can be expressed by international normalized ratio. The international normalized ratio should be 3 or less than 3 in order to perform surgical operation. Actually, international normalized ratio measures the extrinsic and the common pathway, just like prothrombin time. Actually, international normalized ratio also measures prothrombin time, because by definition, international normalized ratio measures the prothrombin time of the patient to that of the prothrombin time of the normal or controlled person. This is actually in order to make prothrombin time measurement standardization, because every manufacturer or for every laboratory there is the people using factors for measurement of prothrombin time. So in order to standardize, these people use international normalized ratio. Patient should be free of infection, as we mentioned before also. Prophylactic antibiotics also can be prescribed to prevent postoperative infection. Use local measures, as we mentioned, local measures such as pressure pack or thrombin gel or Surgisil, collagen fibrils, etc. All these also can be used in case of bleeding in patient taking anticoagulants. Call patient after 4 to 5 days. Actually here, in order to return the patient to anticoagulants normal dosage, this is actually the responsibility of the physician. It is not the responsibility of the dentist. Here, if healing is normal, so the dentist or oral surgeon is responsible to take a decision about healing of the surgical wound, but return the patient to normal anticoagulant dosage. This is the responsibility of physician. Lastly, we have to avoid aspirin and its derivatives. Actually, not, as I mentioned before, not just aspirin, but also all non-steroidal anti-inflammatory drugs, because these drugs inhibit the aggregation of platelets and initiate or induce bleeding. So this is dental management of patient on dicumarol. So what we discussed previously, bleeding disorder due to systemic factors, deficiency in clotting factors, deficiency in the number of platelets or even function of the platelets, or sometimes due to patient taking anticoagulants. In normal person, there is normal hemostatic mechanism. There is no deficiency in the clotting factors or even in the platelets or vascular wall changes. So the person is normal. There is no problem within the hemostatic mechanism. In this condition, there is three types, or local or bleeding or hemorrhage due to local factors can be divided into primary bleeding, reactionary bleeding, or secondary bleeding. Primary bleeding usually occurs during surgical operation, and the most common causes is pre-existing infection, such as in case of advanced periodontal infection, or in case of hypertensive patient, not uncontrolled hypertensive patient, because the patient not checked his blood pressure, and his or her blood pressure very high. So in this case, this may lead to bleeding during surgical operation. Reactionary bleeding, actually here mostly due to dislodgement of the blood clot, and usually reactionary bleeding occurs few hours after completion of the surgical operation. And as I mentioned before, due to mechanical dislodgement of the blood clot, due to mouth rinsing or smoking, or sometimes due to elevation in the blood pressure after the patient controlled, or he is hypertensive but controlled. So we perform the surgical operation. But later on, after a few hours, the patient returns with bleeding. This is due to elevation in the blood pressure due to walking or working and so on. Or sometimes due to wear of the action of vasoconstrictor in the local anesthesia. Once the action of vasoconstrictor wear, in this case, bleeding might also reoccur. The secondary bleeding usually occurs 7 to 10 days after surgical operation, and the most common causes is usually infection. How we can manage these types of hemorrhage? Either by pressure pack, local measures, pressure pack, cotton or gauze, or by the use of Surgisil or Oxysil or collagen fibrils, or sometimes we can use thrombin gel. In case of bleeding from bone, actually, because sometimes the bleeding from soft tissue, as in case of tissue laceration or tear of flap, or sometimes due to severance of the minor blood vessel within bone, as in case of surgical operation of impaction of impacted lower wisdom tooth. There is also bleeding from bone. So if there is a bleeding from bone, we can use bone wax or crushing of the socket in order to close the vessel, small vessels, which were the cause of the bleeding. So also, if there is a bleeder, I mean artery or veins, also we can ligate, use resorbable suture to ligate the blood vessel to stop bleeding. So this is the management of patient with hemorrhage during an oral surgery for normal person. So this is the end of the lecture, and thank you for your attention.